Welcome to the Explainer. For anyone in medical training, trying to figure out a skin rash can feel, well, pretty overwhelming. So today, we're going to tackle that head on. We're going to build a systematic, clinical approach to make sense of it all, and we'll see how the skin can actually be a window into the immune system. Okay, so here's how we're going to break this down. Think of it as our roadmap. First up, we need to learn the basic lingo, the language of the skin. Then, we'll figure out how to read the map, which is all about where the rash shows up. After that, we'll dive into two really common patterns. And finally, we'll talk about how you actually lock in a diagnosis and connect it all back to the big picture of immunology. All right, section 1, the language of the skin. You can't name a disease if you can't even describe what you're looking at, right? So it all starts right here with the fundamental vocabulary. And this is probably the most important thing you'll hear today. Seriously, the absolute most crucial step is just describing what you see. Forget about the diagnosis for a second. Your first job is to be a good detective, and that means meticulously describing the clues. The name of the disease, that comes way, way later. Okay, let's start with our first piece of vocabulary, the macule. It's super simple. A macule is just a flat spot of color. You can see the diagram there showing it's not raised at all. But look at the photo of the mole. That's a perfect real-life example. Here's the key test. If you closed your eyes and ran your finger over it, you wouldn't even know it's there. That's a macule, totally flat. All right, so if a macule is flat, what's next? The papule. And the only difference really is that a papule is raised. It's a small, solid bump. You can see it in the diagram. It's elevated off the skin, and the photo shows these classic purplish, flat-topped papules you see in lichen planus. This one, you can definitely feel this one. And now for the vesicle. The easiest way to think about this, it's just a tiny blister. It's a small, raised lesion, but it's filled with fluid. You can see that little pocket of fluid in the schematic. And then look at the clinical photo. See how those little vesicles are all clustered together? That grouping is a huge clue for this particular condition, dermatitis herpetiformis. So something really important to get is that rashes change over time. What starts out as one thing can get scratched or infected or just heal in a certain way. And when that happens, we get what's called a secondary lesion. Take a look at this photo of lichenification. You see how the skin looks thick, almost leathery, with all those deep skin lines? That is a classic result of someone scratching and rubbing the same spot over and over and over again. Okay, so we've got the what, the basic types of lesions. Now it's time for the where. And trust me, the where is sometimes even more important. This is all about reading the map of the body, because where a rash decides to show up, well, that tells you a ton. Check this out. This map is gold because certain rashes have, well, they have favored hangouts. Take psoriasis, for example. It absolutely loves extensor surfaces, like the outside of your elbows and your knees. But then look at atopic dermatitis. It's the complete opposite. It prefers the flexural areas, the crooks of your elbows, the backs of your knees. Just knowing that one simple fact can instantly narrow down your list of possibilities. It's all about pattern recognition. All right, let's put what we've learned into practice. Our first big pattern is the eczematosis reaction. This is basically a big bucket category for rashes that are red, inflamed, and super itchy. You've definitely heard of these. We're talking about eczema or dermatitis. Okay, this table breaks down the big three types. With atopic dermatitis, the clue is usually in the patient's history. Do they or their family have a history of asthma or hay fever? That's a huge tell. Now for the other two, allergic and irritant contact, it's all about exposure. What did their skin touch? The big takeaway here is that the patient's story, the history, is what really helps you tell these apart. And here we go, a textbook case. This is classic atopic dermatitis, right in the crook of the elbow. That's that flexural area we were just talking about. And you can see it all here, the redness, and also that thickened, leathery-looking skin from chronic scratching. That's the lichenification we saw earlier. Now, this is just beautiful detective work. This is allergic contact dermatitis. I mean, look at that. The rash is a perfect circle, exactly where the metal snap on a pair of jeans would press against the skin. You don't get a better clue than that. The rash is literally drawing you a picture of what caused it. Okay, on to our next major pattern, the papulosquamous diseases. And yeah, the name sounds a bit complicated, but it's really not. Papulo just means raised papules or plaques, and squamous means scale. So we're talking about raised, scaly rashes. Simple as that. So with this group, it's all about spotting the subtle differences. Psoriasis, for instance, its calling card is that thick, silvery scale. It almost looks like mica.
But then you have lichen planus, which is famous for its purple, angular bumps, and pityriasis rosea has this very cool Christmas tree pattern on the back. For this group, the devil is absolutely in the details.
Okay, let's put these two side by side because this is a great comparison. On the left, you've got psoriasis. Look at how thick and silvery that scale is on that red plaque. Now look to the right at lichen planus. Totally different, right? It's got that distinct purplish color, and the bumps are much smaller and flatter on top. Once you see them next to each other, the difference is night and day. So you've looked closely at the rash, you've noted where it is on the body, and you've got a pretty good idea of what's going on. But how do you prove it? Well, that's what this next section is all about, confirming your diagnosis. You always want to follow a logical progression, kind of like a ladder. You start on the ground floor with a really good history and physical exam. That's your foundation. Then, if you need more info, you can step up to simple tests you can do right there in the clinic. And only if you're still stuck do you climb to the top rung, which is a skin biopsy, to get the final answer. And don't underestimate these simple in-office tests. They're incredibly powerful. A KOH prep is great for fungus. You scrape some skin, add a drop of potassium hydroxide, and it basically dissolves the skin cells, leaving the fungus behind to see under the microscope. A tank smear is for viruses like herpes. You're looking for these very specific giant cells. And of course, patch testing is how you nail down the exact culprit in an allergic contact dermatitis case. Okay, for our last section, let's pull back and look at the really big picture. Because what's happening on the skin is often a reflection of what's happening inside. This is the idea of the skin as a window into the immune system. This quote really brings us full circle, doesn't it? It perfectly sums up the challenge. It's tough. You have to see the subtle differences and then weave all those signs and symptoms into a diagnosis. But hopefully, what we've shown is that if you have a system, if you look at description, then distribution, then pattern, you can absolutely make sense of the chaos. And that brings us to our final thought, and it's a really important one. When you learn how to do this, you're doing so much more than just diagnosing a simple rash. So many important systemic diseases, so many immunological conditions, their very first sign appears on the skin. So the real question we want to leave you with is this. Now that you're starting to read the language of the skin, what major disease are you going to be the first to catch?